Okay. So again, Karen Mulvihill, welcome. We are thrilled to have you, and we're excited to hear about palliative care during the pandemic. Thank you.
Yep. And you can see my presentation?
Yes, I can see it. Can
Perfect.
everyone else
Thank
see
you.
it?
Yep. Deacon
Okay.
David said yes. I appreciate it. Thank you. Okay. So thank you all for coming. Today I am going to define palliative care and some of the definitions that we use. We're going to identify some of the challenges we're seeing with the seriously ill population during the pandemic. We're going to discuss some of the innovative ways that the palliative care teams were able to step up really for everybody, for patients, for families, for staff, for each other in all the settings, whether it was in the hospital or in the home setting. And we're going to identify ways we can move forward and past and beyond this and support each other. I don't have a lot of slides. I tend to talk a lot. So I wanted to kind of make it as specific as I can, but leave you with the key points that we were talking about today. Feel free to put anything in the chat if you have any questions. And at the end, I'll be glad to have further discussion about any of the points that I've talked about. So first and foremost, what is the definition of palliative care? There's lots of them out there. We really want to make sure everybody talks the same language when it comes to palliative care and defining it. So I think it's an important place to start. The state of Connecticut has a definition for palliative care that I actually helped create, and this is one of the definitions that we use so that we do all understand and talk the same language. So palliative care focuses on expert assessment and management of pain and other symptoms, and assessment and support of caregiver needs and coordination of care. We look at the physical, functional, psychological, practical, spiritual, existential, anything that is causing any impact on their serious disease. It's person and family-centered approach to care, and we provide people living with serious illness with relief of those symptoms and stress of illness by providing them with the resources they need to be able to have the best quality of life, whether it's days, hours, months, years. And we know that through early integration of palliative care, that patients can have an improved quality of life, and in some instances, even live a little bit longer. So it's quite an exciting thing to be part of. That definition from the National Quality Forum continues to go on and say that it's appropriate at any stage of illness. So we're not talking about patients who are at the end of life and hospice appropriate. This is long before, and I'm going to talk more about that in a minute, but palliative care really should come at the time of diagnosis of a serious illness, not when we're now looking at a patient at the end of life where we're wanting to call in hospice care. Provided over time to patients based on their needs and not their prognosis. Offered in all settings by various types of organizations, whether it's primary care offices, health systems like we have, cancer centers, home health agencies, hospice agencies, and even in long-term care facilities. We focus on what's important and what matters most to the patient and the family, and assessing their goals and preferences to help them determine how best to achieve what matters most. And that may include things like guiding them through treatment options and what's most appropriate for them. What type of care will be most appropriate for them at this point in their illness, or even future planning. We provide interdisciplinary care to attend to the holistic needs of the patient and the family. And their caregivers as well. A lot of our families in the community, as some of you I'm sure know, have paid caregivers that come in as well. And when we see patients in the community, we include those paid caregivers in our discussions as well. Because if they're not on the same page as the patient and the family, we can hit some conflict in the care. The World Health Organization also has a definition of palliative care, and that's an approach that improves the quality of life for patients and their families facing serious life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other symptoms. Again, we want to focus on symptom management. We want to affirm life and really regard dying as a normal process. So again, even if we're talking about getting involved with somebody newly diagnosed with dementia in the community setting, whether it's Alzheimer's dementia or another type of dementia. There's a lot of conversation that those people can participate in before their dementia gets too severe. But it's also important not only to affirm life and to give them the best quality for the years down the road through this diagnosis, but also to talk about what end of life might look like for that diagnosis in the future in a gentle, kind, appropriate manner. We don't hasten or postpone death. We really focus on looking at the natural process for that disease, that specific patient and what they're going through, and really offering them support as to comfort and how what we're doing is not hastening nor postponing death. We want to always make sure we include the psychological and spiritual aspects of care. The hospital, it's easy. We have our interdisciplinary team at our fingertips, and that includes our wonderful caregiver center, our chaplain services. We have a social worker in the community. It may be reaching out to our behavioral health specialists in the primary care offices, or to their parish, or what church they belong to, what religion, so that we can pull in any spiritual support that they may need. We want to offer support to the patients as long as possible, and to the family with coping during the patient's illness, and then also, as if it's appropriate, during the bereavement time after the patient has died. Again, we're using the team approach. We want to enhance quality of life. And again, it's applicable early in the course of illness and in conjunction with life-prolonging therapies such as chemotherapy and other, it could be dialysis, it could be other things that normally, when you're talking about hospice care, really isn't included in that plan of care when you're talking about real end of life. So we want to get involved really early in the course of care. And this is kind of my picture of what palliative care looks like. To me, it's an umbrella. Palliative care is a really big umbrella, and it includes a lot of things. Managing serious chronic life-limiting illnesses. We have our symptom management, our quality of life. We want to walk with them through their active treatment so that they can do better and have a better quality. We want to talk about advanced care planning early. Part of palliative care is hospice care, and that's when the patients are closer to the end of life. They no longer want to proceed with any kind of curative treatment for their disease. So no more chemotherapy, or I don't want to keep coming into the hospital for my respiratory problems or my heart problems. I want to stay home and focus on my quality of life. That's when we call hospice in. So hospice is a type of palliative care that's meant for the end of life. And then also the bereavement care for the families and the caregivers afterwards is included under that umbrella of palliative care. So it can be very broad. We do a lot of different things. Some new topics that I've come across in palliative care are cancer survivors. I do outpatient oncology as one of my practice settings that I work in, and I have several patients who have prolonged symptoms from chemotherapy. They may be cured of their cancer, they're survivors, but they have some lasting symptom management issues around that treatment that they had to go through for their cancer. So there's different places to be able to fit palliative care in. So I'm going to talk a little bit about COVID and some statistics. They're old now, because a week later everything's changed. Just to kind of give you some idea, we all lived it. We were all there through it. It was scary, and we needed to move very quickly to be able to take care of all of these patients who had COVID. And us in
All right, I got it.
Okay.
I'll leave you in.
Welcome to stay.
Can you make sure your Zoom is muted, please?
Or your phones.
Or your phones, yes. So I'm sorry, getting back to the COVID. So us in this area of the state, in the Danbury area, we're the first in the state to really see COVID. back in March, and were really the hot spot in the state for a while until it started to spread slowly across the state. So as of November 4th, the total cases in Connecticut were 74,000 cases of COVID. There were, on 11/14, there were 381, or I'm sorry, on 11/4, hospitalized patients, with about 4,600 deaths since it started. The peak of the deaths occurred in April, actually on April 20th, where the state saw over 200 deaths in one day from COVID virus or COVID-related illness. We've seen now, and I know you've heard it in the news, and the governor kind of going back to a different stage of protection for our state. We're kind of taking a step backwards, and we're seeing more and more positive cases in the community. And more hospitalizations over the weekend. I think I got an alert from the Department of Public Health that on Friday, we had maybe 96 patients in the hospital across the state of Connecticut with COVID-related illness. And as of Monday, it was almost 500 patients. So it's coming back. And how can we now, with everything we've learned over the last 6 months, protect ourselves and our families and our loved ones? And how can we give them the best care, if they should have it, possible? And that's a little bit of what I wanted to talk about today, is kind of how to have conversations with family, loved ones, patients, whoever you're encountering on a regular basis, to give them the support that they need. So in healthcare, we had a lot of challenges. It was really hard for palliative care staff, because and as it was, I'm sure, for the chaplain staff and the caregiver staff, it's hard to not be able to touch somebody and have that skin-to-skin contact, give them comfort that they need. We weren't allowing any visitors. Even my patients I see in the home setting, they were limiting how many family members can come in, really trying to keep people very isolated. And that lack of human touch is detrimental to a lot of patients, especially those with dementia, to just not even be able to see your face. So my practice right now is oncology and home visits. I do a lot of home visits. And I was in a home yesterday, and I was realizing, as I have my 2 masks on and trying to protect myself and my families that I'm taking care of, that a lot of my patients have never even seen my face. They have no idea what I look like. I can see them in Stop and Shop, and they would have no idea it was me. That's sad to me. That breaks my heart, especially in palliative care, where the goal of what we're trying to do is establish trusting relationships with the patients and families, give them comfort. And now we're faced with patients alone in an isolated room, limited staff going in and out, who are covered from head to toe, just like this picture, when they do go in, and not even going near the patient if we didn't have to. So it really was a sad time, I think, for the healthcare profession to not be able to do what we do best in providing comfort. I think as well, thinking about the nursing home population. I don't know if any of you, some of the chaplains go into nursing facilities, but we're no longer allowed to go into nursing facilities. But I have friends, and I know of patients that we've taken care of whose loved ones died in nursing facilities, not from COVID, but seriously because they firmly believe it was because of the lack of interaction and the isolation that they faced during COVID. One of my friends would go and visit her 96-year-old mom every day after work, have dinner with her, and then, go on to take care of her own family. Her mother died. She died of loneliness. She's convinced 100% she didn't have COVID, that the facility never even had a case of COVID. And that's not the first case I've heard of that. That isolation for that population is so frightening. And how can we, as staff, as caregivers, as loved ones, be able to support our families through this? So to me, communication was key. At that time, there was a lot we didn't know. We didn't know much about even prognosis, right? We had patients who looked like they weren't going to make it on ventilators for weeks, and they recovered. You know, they just needed time. Acknowledging that we don't know everything was important. So we don't know how this is going to go, but we need to prepare. And I think that's part of what those of us in palliative care really tried to do with staff, with families, with caregivers is express the fact that this is all unknown. We don't know what it's going to turn out to be. But if it doesn't turn out as we hope, which would be obviously you walk out of here like you came in, what would you want in place for your loved one? And really having those conversations. We tried very hard to make sure patients didn't die alone, but that was really difficult in the COVID units. There just wasn't enough staff. There wasn't enough of us who were willing to go in to a COVID positive room or an ICU room where the highest risks were, to be able to sit with those patients and be with them when they died. The staff was stressed. Obviously, they're scared, they're stressed, they're overworked, they're working many hours, and they're feeling sad and upset over the whole situation as well, because their patients are alone, and that's something that we never want to have happen. Our families were stressed because they had no idea what was going on with the patients, with their loved ones. They didn't know what to do. Who do I reach out to? How can I see them? And as we got farther along in the COVID crisis, say into the end of April, end of May, a lot of the patients were from nursing facilities coming into the hospital, and the families hadn't seen them in months at that point. So they have no idea what their loved one looked like or what was going on or how they were feeling. We don't know, are they at their baseline? Is this their baseline or is this not their baseline? How can we tell where they're at? So I think with the help of the caregiver center and the chaplains and the patient experience team, we were really able to get into place and do a lot of Zoom family meetings where the families can just, even if it's me, I'm going in with my iPhone and I'm like, I'll call you when I'm in the room, and doing FaceTime so that they can see each other. I think we really went above and beyond to try our hardest to connect patients with families with technology, which isn't the best, but at least it was something, and they felt like they were at least seeing their loved one. So it was a very challenging time. So what did we do as palliative care in trying to help ease the strain? You know, we were fearful about a lot of things. The unknown of the disease itself. Is there going to be treatment? Are we going to be able to move past this? The what ifs. What if we do run out of ventilators, right? That was always on the mind and in the press and in the news. And do we have enough PPE? And that was really scary for all of us, in anywhere for that matter, caring for our loved ones or our patients. So what we did really right out of the gate, like the first weekend, was we put together, and I'm going to show you some examples of what we did too, excuse me, on how to have conversations with these patients and their families when they came in by themselves, and how to talk to a family over the phone and ask, you know, what's most important to your loved one? Is it, you know, somebody who is in their 40s who has no comorbidities, no other illnesses that are impacting their COVID infection, where we're hopeful they maybe will recover, but we don't know what that's going to look like? Or is it, you know, the 96-year-old nursing home patient who has advanced dementia and heart disease and lung disease, and you know, we don't know how this is going to go. You know, if it doesn't go as we hope, what would you want for your loved one? So really learning how to have those conversations, how to support the unknown, and how to get families to verbalize what mattered most. And on that side of it, on the family side of it, a lot of times when we were calling, we would hear things like, well, you know, you're not gonna treat them as you would because they have COVID, right? And because they're elderly, so they're not going to get the ventilator because of that. And that never happened. You know, that was never something, but it's what matters most to this patient and the family. So some of these conversations were really difficult, and I will show you some examples of how to do that, because I think having those conversations is important for all of us who deal with, whether it's patients, coworkers, it's other family members, because you're taking care of somebody in your family at home, and how to kind of talk about these things, I think, is very important. So really understanding what matters most as soon as the patient comes into the hospital, if not sooner. So we did a lot of work in the community setting with the primary care physicians, with visiting nurse, with the emergency department, in talking about advanced directives. So who should be making decisions for you if you're unable to, and really finding out how aggressive of care they would want us to do for them or their loved ones if things didn't go as they wished. So here were some of the goals of care tips that we got and found and shared with all of our staff at the hospital, actually across the whole network, both the Connecticut and the New York side. Things not to say to patients and families. And I think this is important for all of us on this video right now to understand, because even if you're not a nurse or a caregiver in the hospital setting, but you're a family member taking care of somebody at home, these don't says are things you shouldn't ever hear, right? So these should be your red flags. And the response of the try these instead are great ways for you to be able to bring up this conversation with the physician, with the ED, whatever it might be, your primary care doctor, about the care of your loved one. And how about we look at it this way, instead of saying, what would you like us to do if your heart stops? Well, even my heart stops, I want you to do everything, I want you to make sure. What does that mean? What does that look like? And really kind of thinking of, do you want us to do everything is another thing. Oh, of course I do. I'm in the hospital. I want you to take care of me. Well, what does that actually look like? So, well, for you with, end stage lung disease, and now you're in here with COVID, and it looks like it's getting close to us needing to put you on that ventilator, everything for you would look like this. It would look like putting you on the ventilator and sedating you and having to do aggressive care. And then it's possible you won't be able to come off the ventilator. And would you want to live on a ventilator? Would you want to go to a nursing home? Things like that. So everything to me may look very different than everything to you. And that's important to have that conversation. So instead of talking about, do you want us to do everything? Let's talk about what my goals are, and let's try to do a plan of care around that. Withdrawing care is a horrible word, right? Withdrawing is very negative. We don't want to really term it that way. We don't want to term it, that would be, withdrawing care would be taking somebody off a ventilator if they weren't able to come off on their own. Or like right below it, that term terminal extubation means really that same thing, that we're expecting that they're really not going to breathe once we take them off that ventilator. But there's other ways to say that, right? This is the plan of care that's best for this patient. This is what's going to make them more comfortable. We can't cure them, we can't make them better, but we can focus on comfort. So it's never giving up. It's never withdrawing care, because there's always lots of things we can do for that patient and that family. Whether it's just providing comfort, symptom management, the chaplain, whatever it might be, being able to do a lot through that period of time. And again, that last statement, there's nothing more we can do. Yes, there is a lot more we can do. And those of us who take care of people know, right, there's plenty we can do, even when it doesn't involve going to the hospital or getting chemo or going to dialysis. They still need a lot, and we can do that for them. And that will never stop caring for them or their loved one. So when talking to patients in the hospital, in the community, wherever it may be, your loved ones, what does it mean that I have COVID-19? What does that mean? It means that you tested positive for it, right? And what can we do to help keep you more supported and comfortable? How bad is it? Now I think we know a little bit more than we did initially, but we didn't at the beginning. But, really looking patients over. I'm going to talk more about the home setting as well, because again, that's where I see a lot of patients and families. and am now starting to see, and at that time as well, some things come up in the home setting that we'll talk about as well. But how bad is this? You know, the one thing with COVID is there was nothing consistent, right? Everything was very different. It could be that 96-year-old patient from the nursing facility with dementia did fine and managed to get discharged and go back to that facility, God bless them, you know, and ended up doing okay, versus a younger, healthier patient who doesn't do okay. So we just don't know. But what we do know is that we can take it day by day, and we can always update patients, families, caregivers as things change. Are they going to make it? You know, using phrases like, I wish things were different. I imagine you're scared. And here's what I can tell you about what's going on. That he may not make it, you know, but honestly, it's too soon to say, and we'll just take it day by day, are really great ways to kind of approach families when they bring up questions about the prognosis, because it's just too unknown. Those of us in palliative care, and I say this a lot, we don't get it right with prognosis. Even in the most predictable type of scenario, we don't always get it right. So there's just so much unknown, and we just need to be honest about that with our families. When things aren't going well or as expected, you know, I want everything possible. I want to live. Okay, well, we're doing everything possible, and this is a tough situation. What do I need to know about you to take better care of you? It's a question my palliative care team asks every single patient and family that we encounter. What is most important to you? What do I need to know to take better care of you? I don't think my spouse would have wanted this, right? Because patients were coming in, things were happening quickly. The family's not there to advocate for their loved ones anymore. So really taking that pause and talking about what they would have wanted, and what they considered most important in their life, what gave them meaning and purpose in their life, and really getting to know them and base that plan of care around that. Many patients were saying things like, I don't want to end up being on a machine or being a vegetable, is what we hear all the time. Well, what does that mean exactly for you? What does that look like for you? What are you willing to go through if some improvement is possible? What is some improvement to you? So really kind of trying to talk through some of these things. And even when they don't know what their spouse or their loved one would have wanted, because they never talked about it, which is still a problem, but that's a whole nother presentation on advanced care planning and goals of care. That's for another one. But we find many people in this boat. They just don't have the conversation. And that makes it very stressful for families and caregivers to be able to make proper decisions. And in healthcare, what we really try to empower providers to say to families and patients sometimes too, is what is our actual recommendation based on that specific patient. So really focusing on patient family-centered care, saying with all of your illnesses, this is what I think should happen. This is what I would recommend from my experience, and based on what you just told me matters most. This is what I think the best plan of care would be for your loved one. So just some tips on how to communicate with families during this crisis. When coping needs a boost or emotions are running high, I'm scared, you know, we heard that a lot. It's a tough situation. I think everyone would be scared. Tell me more. What are you most scared about? How can I help you with that? What other resources can we pull in? Is it the unknown? Saying I'm scared as well because I don't know the answer to these questions either yet, because this is all so new, you know, and really being with that patient and present, whether it's over the phone on a Zoom meeting or you're able to be at the bedside. I need some hope. Well, tell me about the things you're hoping for so that I can understand more about that, and let's talk about it. For patients who are not doing well and nearing the end of life, I need to say my goodbyes. You know, of course, we're hopeful that's not going to be the case. But I worry in time could indeed be short. What is the most pressing thing on your mind? And how can we help you achieve that, even when it's not going to be face-to-face at this point? So supporting each other, staff and caregivers, how do we help each other? I'm scared. I'm scared going out. I'm scared going into the hospital every day. I'm scared going into the home setting, into the office setting, and really just validating each other's feelings. Like, yes, a lot of people are scared. I'm scared too. But what are you most worried about? That one question will show support to your colleagues, to your friends, to your family. Again, I'm worried we don't have enough ventilators to care for all the patients. That's the ultimate, right? The ultimate decision-making that we would ever have to make. And we're so grateful we never had to do that. But none of us were in that alone, and neither were the families or the patients. We were prepared to be able to face those. I'm worried I'm going to bring COVID-19 home to my family. Those of us who come into the hospital, and I'm going to talk a little bit more about the community too, because I think now it's even more important. But those of us in the hospital setting where we were most exposed, we know through some research studies that we did that even those of us who worked on the COVID units, we didn't get it. We protected ourselves. And I think the PPE and knowing how to do that is the most important thing that we can do for each other. So sharing the PPE and how to use it properly. If you're in the home setting and you're taking care of a loved one and you have caregivers coming in and out, really understanding what they should be doing to protect you, themselves, and your loved one is very important. And I'm going to talk more about that. I'm worried I'm going to get COVID. I didn't have COVID. I'm worried I'm going to get it. And then what is it going to look like for me? That's always a scary thought, especially seeing a lot of what we were seeing were the really bad cases is what we were hearing about. But a lot of patients ultimately were cared for in the community at home and did okay. That's the majority of patients who had it. So it's important to keep that in perspective. So what did we really do for support across our network? We had frequent check-ins with staff, with each other. So my palliative care team, even though we avoided face-to-face contact with each other, we would do Zoom meetings, we would do calls, we would text each other, we would check in. Family members could do that. Other members of the care team can be doing that as well. Reassurance that we're trying our hardest to connect patients, families, and caregivers with each other so that they feel supported, and really helping when we can. It was a lot to put that PPE all on and go into a patient's room. And the patient needs something like water or a bedpan or something very simple. I'm not going to waste this PPE and leave so somebody else can put on PPE and come and do it. I'm going to do what I can for that patient while I'm in there. So we were finding ourselves doing, as nurse practitioners and physicians on our team, and I'm not sure about the chaplain team and Lynn, but we were going back to our nursing days of helping with bed baths and doing vital signs and, things that we don't normally do on a daily basis just to help the staff and to preserve our PPE. We also did some amazing cross coverage to our New York partners in New Vance Health. I did a lot of telehealth visits and helped cover Putnam Hospital and their palliative care. They had a lot of nursing home patients come into that hospital from that area, and really just tried to support them and their families, who were so very grateful to have had somebody to be able to talk to. And I think as an organization, we did an amazing job using some of our staff that were no longer in their usual areas because those areas were closed, such as the ORs and ambulatory and things like that, to be able to call and support families through this crisis. It really was amazing. We had lots of people calling the patients or the families to offer them support. We tried our hardest to provide comfort to families over the phone and keeping them connected. We did lots of family meetings via Zoom whether it was, it was amazing because I think we all had to learn so quickly how to do this stuff, not usually within our norm, but we would have family members, 6 family members on a family meeting talking about what matters most to their mom from all over the country. And it really showed, I think, that we are able to pull and connect families together in a way we just never did before. And I think it provided some amazing opportunities. And with staff too, and involving staff in different areas. So how do we move forward? Before I talk about, oh, this isn't the right presentation. I did update this presentation. I'm gonna unshare for a minute and reshare because I wanna talk a little bit about caregiving in the home as well. Which one is this? Because what we're seeing now with COVID is a lot of the COVID is in the community. Oh, how do we do that? And bear with me 1 second. This is what happens when you update your presentation at the last minute. Oh. Here we go. Let's see if this is it. Nope. I'm sorry for the technical issue. But what we're seeing a lot in the community is caregivers, so paid caregivers in the community who are now having, this is the one I want, who is now having, coming into work with COVID. And that's a challenge. Okay, I am back. Let me share my screen again. And Deacon David, can you see that? As I see you on my screen. Can you see the presentation, support for family? Thank you. So what we're finding now is that the caregivers are coming in and then finding out that they have been exposed to COVID because they're going from family to family, patient to patient, house to house in the community setting. And I think a lot of families don't necessarily understand that they need to find out what those agencies are doing to screen their caregivers, right? Because a lot of these people depend on that income and they're going to come to work if they have a fever because that's what they've always done. And nurses are notorious for that. If I don't feel good, it's nurse's guilt. I'm coming to work unless I am like, have a fever, I can't get out of the bathroom, anything like that. Otherwise, I'm coming to work even if I have a cold. Where now we really can't look at it that way because that cold symptoms could be the beginnings of COVID. So if you're in the home setting, whether you're a caregiver, you're a nurse, you're whoever going into the home, clergy going into the home, you want to always make sure that you monitor your loved one for fever. Do they have a new cough? Are they having more difficulty breathing? Do they all of a sudden have a loss of taste or smell? You want to make sure that you screen yourself if you're caring for somebody where there's lots of people coming in and out. Do you have, how are you feeling? Are you doing okay? The paid caregivers, it is okay to ask them when they walk in the door to check their temperature. You know, what is your temperature today? I want to screen you. Do you have any symptoms? Have you traveled outside of Connecticut in the last 2 weeks? It is absolutely okay to ask anybody that comes into your home or whose home you're going into those questions before you go in. And for families who work outside the home as well, making sure that we're kind of cutting back like a little bit like we were in the spring with limiting number of visitors. Because it is in the community and a lot of it is from the caregivers. It's from restaurant staff, it's from being out, just doing the things that we missed so much doing for months and now we're finally back to doing. We need to take a step back now and kind of protect the people in our lives that we're taking care of. Get tested. You know, there's testing everywhere now. It's very easy to get tested. So if you think that you're not feeling well, If you don't know if it's allergies or if it's a cold or if it's coronavirus or the flu, make sure you go get tested. There's lots of ways to do that. Make sure you get a flu shot, speaking of the flu, because we don't want to overburden our healthcare system with flu and COVID, because then that would be way too much. So the recommendations this year are very much around making sure that everybody gets their flu shot. When the aide comes into the home to help take care of your loved one, again, ask them those screening questions. If they've had a temp, if you're not comfortable, don't let them in. I know it's a burden because they're there to help, but don't let them in. Call that agency and find out what their policy is around screening and testing their staff. Many nursing homes are testing weekly their staff to make sure that they're not infected. Wear a mask at all times when you're around your loved ones or around people that you don't know where they've been. It sounds funny to say it that way, but you know, are they somebody who's out and about in the community a lot? Do they work in a big office where they are exposed to a lot of people and there's not good social distancing? We want to make sure we follow those rules to the best of our ability. That is what's going to help keep us safe and keep this infection rate down again. And don't be afraid to ask them to take their temp. That's the number one thing. You need to protect yourself and your loved ones. So moving forward, we're going to continue with everything we're doing to support staff, support the community, the caregivers, each other. We want to make sure as well that we know how to communicate with patients and families during this time again. And we also want to make sure that you're all taking care of yourselves too. As this is such a stressful time, what are we doing to take care of ourselves? Because if we're not healthy mentally and physically, how are we going to care for our loved ones and each other? So it's really important to think about how to do self-care for yourself during this stressful time. All right, and I thank you, and I'd love to have some conversation. Be sure to unmute if you do, or you can put a question in the chat box as well as I have it up.
I'll make a comment. I am both a registered nurse and a caregiver for my husband that has multiple sclerosis. I received a call about an hour ago from the palliative care nurse at the VA hospital. My husband, who's had MS for many years, we decided for the past 9 months to not have any help. The caregiver on March 2nd came in and had said he had just gotten over a cold. So I realized not good. So a lot of what you just said about the palliative care aspect, being on both sides as a nurse and a caregiver, it truly hit the nail on the head. And basically what she called about was because my husband did have a respiratory arrest a couple nights ago, and they wanted to do a swallow study on him because he revived so quickly, but I knew there's no way he's going to pass it. I had to find my voice. When you don't have the ability to advocate when someone is in the hospital and maybe cognitively not there yet, this has been the most frustrating admission of our lives. It's only been the past 3 years, even though he's had it for 40 years, that we've ever had to deal with hospitals. But the communication is so difficult. So what I had to say was, please go in a room, take off your mask. I can't hear you. You have face shield, you have the mask. It was so difficult. So I was able to express, this is what our course has been. This is what we see going forward. So I guess the biggest thing I came away with is communication. Yeah. Even though it's a challenge, somehow you have to find your voice and speak up because they can't speak. I know that hopefully in the next couple weeks he is going to get weaned off and be able to do whatever, but maybe not. So I have to be prepared. And the palliative care nurse, initially I never wanted to speak to her 3 years ago when I met her. Yeah. I'm old-fashioned. My nursing is from many years ago, and it meant end of life. And I literally told her, we're not there yet. He's just on a respirator. He's going to get off out of the room. But now, after seeing her twice for 2 different hospitalizations, she is my liaison. So that's where I'm coming from. And I wish the other caregivers well that are out there doing it, because it's been a long, lonely 9 months. Fortunately, he's my best friend and normally able to communicate, and we're at a house and a place we can live and not have to worry about not being able to get out. But it's been a challenge. So I give my best to everyone out there that's trying to do the juggling act.
Yeah. Well, I wish you the best too, and your husband, and I hope he does well.
Thank you.
Hope he does well.
And thank you for you being the support at your place, because now I see firsthand how vital it has been as far as our liaison goes.
Yeah, absolutely. Absolutely. Thank you for that.
Karen,
Hi, Lynn.
I'm just wondering if you could tell us all, if we have a loved one in the hospital
Mhm.
and we would like the support of palliative care, how we would do that.
That's a great question. Thank you, Lynn. So I think, so I will tell you that all the hospitals in the state of Connecticut have some palliative care support. So depending on where you are, like Karen's experience with the VA, they have quite an expansive palliative care program. So the best way to get palliative care for your loved one is to, if they are calling, so say you're not here and the emergency department is calling, or the physician is calling, that's the attending for your loved one, let them know you want palliative care involved. Absolutely. If you get nowhere, then call the hospital's main number and ask for the palliative care department and ask for a consult directly from them, because we will absolutely advocate for you in getting involved and getting the physician or the team to understand why palliative care is important and why we can help in this situation if they don't agree with it. So there's always a way. If you can't get it through your physician in the hospital, your primary care physician can reach out to us, or again, you can reach out directly by calling the main number of any hospital that you happen to be dealing with and asking for the palliative care department. What else? Any other questions or comments? Well, I hope you all stay healthy and well. Protect yourselves, protect your loved ones, and be safe during this season. And
Erin,
thank you, Miranda, for having me.
Oh, thank you so much. It was incredibly informative. And, you know, I think it's really, you bring up so many points, not just about palliative care, but also about self-care. And that's really important these days as well. I always describe palliative care as this big hug, because it really does embrace the patients and the families in multiple ways, like you said, physically, spiritually, emotionally, mentally. And you have an incredible team, and we're so lucky to have you.
And we're lucky to have you in the Caregiver Center as well, because I know we needed you. All of you were so supportive to everybody during the COVID crisis as well. So we really appreciate it.
Well, thank you. It takes a village.
Yes, it does.
It takes a team. And thank you all for attending today. It's wonderful to have you here. And thanks again. Really appreciate it.
Have a great day, everyone.